This next group of drugs are quite interesting. These are the hallucinogens. These are drugs that can cause hallucinations. And these offer profound distortions in the perception of reality. And so these patients that are on these drugs actually see and hear things that do not exist, that aren't actually happening. And so various cultures over the millennia and over the centuries have used plants to induce these visions and provide some mysticism. Many of these are mind-altering chemicals that are structurally similar, you can see here, to serotonin. And so a lot of structural similarity here. And these are not really associated with dependence or addiction per se, although repetitive exposures can lead to some tolerance. But these are used for kind of spiritual or coming of age type ceremonies historically, and are abused in modern times to produce some of these vivid hallucinations. LSD and other drugs that are kind of within that category are serotonin agonists at postsynaptic serotonin receptors. Excuse me. And you can see an increased glutamate release when these drugs are bound to the presynaptic receptors. And so there's both presynaptic and postsynaptic activity affecting neurotransmission. The kinetics of some of these hallucinating type molecules are interesting. They can be taken orally, where you have an LSD-soaked paper called a microdot or a blotter acid. Some of these effects can occur within half an hour to 1.5 hours after the drug is ingested, but the effect may last up to 12 hours. You can see liver metabolism and some rapid tolerance manifesting itself. The LSD adverse effects can be divided again into kind of short-term, both physical and psychological, as well as long-term, where you can see persistent psychosis as well as flashbacks, depending on how much and how frequent some of these drugs are abused. The other drug is a derivative of amphetamine, and this is ecstasy, MDMA, also called Atom on the streets, or MDA. This drug has been synthesized in the early 1990s. I'm sorry, the early 1900s. The patent for cough syrup was actually first issued in 1940. Sorry, and it's been used since then for different reasons. Now it's used as a street drug. Since the 1980s or so, was popular at raves, and those euphoric effects occur within the first 15 minutes of ingestion. And some of these tablets that are made look like this, and so they look rather innocuous. They look like they could be candy, but they're not. And you can see some indirect serotonin agonist activity. And so these drugs will promote the release of vesicular serotonin, but when in the terminal, the MDMA interferes with the storage of serotonin, and also interferes with the amount of serotonin available to be released. They can be increased. The kinetics of ecstasy tell us that it's orally active. You can see relatively nice absorption in the GI tract. There's liver biotransformation or metabolism. And ironically, the metabolites that are made by the body actually interfere with the body's ability to break down more ecstasy. So, that's really scary. The euphoric effects occur within about 15 minutes, as I said, of ingestion. So at low doses, you can see relaxation, serenity, what they define as emotional closeness. At moderate doses is where you see some of these hallucinations occurring. You can see an intensification of feelings. And then at the higher doses are your classic, amphetamine-like effects. And so the production of cardiac arrhythmias, the production of hyperthermia, as well as hypertension. I think this next figure is fascinating. Here's serotonin present in the cerebral cortex. And so here's your kind of control. This is what this portion of the brain looks like 2 weeks after ecstasy. And you can see there's still a reduction in some of these serotonin neurons after 7 years of this drug. And so this is kind of like that classic commercial from the 1980s. This is your brain, and then this is your brain on drugs, and they take a an egg and they fry it in a skillet, and then at the end they scramble it, basically saying that your brain is going to turn into mush. Let's go into the next group, the CNS stimulants. And so these drugs offer psychomotor stimulation, and the notoriously well-known, and you may even be drinking it right now. Sorry, I had technical issues. You may even be drinking it right now, is caffeine. Other drugs that are considered psychomotor stimulants include nicotine, cocaine, amphetamine, and methamphetamine. So let's kind of talk about cocaine. This is the most widely used psychoactive drug in the world. Basically, it's a mild stimulant, and it's naturally occurring. So just because it's natural doesn't mean it's good for you, right? But coffee, tea, chocolate, of course, all these drugs have, or all these drinks have varying amounts of caffeine, and some of the more popular soda and other drinks are listed here with their approximate caffeine content. From a mechanistic standpoint, caffeine's effects are mediated by blockade of the adenosine receptors. And so the adenosine, remember, is a neuromodulator. It actually can modulate several neurotransmitters: norepinephrine, dopamine, glutamate, GABA, and so forth. From a kinetic standpoint, we typically take this drug orally, and it's also part of various preparations. You can see caffeine in certain stimulants, painkillers, because caffeine actually synergizes aspirin derivatives. It also can increase their absorption because there is a dopamine receptor component to caffeine within the GI system as well. And you can also see it with cold preparations and diuretics. And so from different dosing effects, I'm sure you're all familiar with the normal doses of caffeine: alertness, sustained attention, faster thought, reduced fatigue. There is some fine motor coordination and timing that may be impaired, and you can see people that do surgery tend to avoid caffeine for these reasons, although you would think that it would help their lack of sleep, especially for, like ER surgeons and so forth. But some of their fine motor coordination might be impaired. Heavy doses of caffeine, however, can produce insomnia, anxiety, and agitation. And the withdrawal syndrome, which many of us may or may not have experienced. I have when I tried to quit caffeine a couple of years ago, and that's basically due to the increased receptor density and increased sensitivity to adenosine, include lethargic feelings, irritability, and headache. And so the caffeine withdrawal is very unpleasant and a real thing. Likewise, nicotine, one of probably 4,000 chemicals found in tobacco smoke. You can see it in cigars, cigarettes, pipes, hookahs. Now we've got those electronic cigarettes and chewing tobaccos and so forth. It's all nicotine. And it's the major psychoactive ingredient in any tobacco product. So nicotine is obviously an agonist at the nicotinic receptors. And so remember, these are acetylcholine receptors, which can be found in both the periphery as well as the CNS, which is why these drugs are so habit-forming and difficult to kind of eradicate. When it stimulates at low doses and at high doses, it can cause blockade. Typically, you see stimulation and release of dopamine from the ventral tegmental area, which is thought to derive where some of the dependence liability comes from. There's also a monoamine oxidase inhibition component to nicotine in the CNS as well. It's got interesting kinetics. It's highly lipophilic. It crosses the blood-brain barrier, and it also crosses the placental barrier, which is why we tell pregnant women not to smoke. The peak effect basically occurs within about 10 seconds of inhalation, and the half-life is only 30 minutes, which is why smokers are routinely going out for smoking breaks. And of course, we all know tolerance develops quite rapidly. The acute effects look to be sympathetic. You can see an increased heart rate, increased blood pressure, increased sympathetic tone, increased stomach acid. The chronic effects include sedation, nausea, mental confusion, respiratory depression, and in some cases even coma. And the withdrawal effects are unpleasant, producing anxiety, insomnia, tremor, the inability to concentrate, irritability, and an intense craving for tobacco. And so to kind of curb that, we can use nicotine treatment options, one of which is varenicline. This is a partial agonist at the CNS nicotinic receptors. And so what it does is it basically goes in there and blocks the ability of some of those receptors to produce their physiologic effect. And so that's kind of the distinction between, partial agonism and antagonism. So there's some mild activity there, but you can see that it greatly reduces nicotine's effects. Other nicotine-dependent treatments include bupropion, and here we're going to inhibit the reuptake of dopamine and norepinephrine, as well as various preparations of nicotine patches, gums, lozenges, and sprays.